Morning, everyone, and it's really a true pleasure and honour and a privilege to be able to join you here. Thank you so much for the invitation, Chris and Caroline, the entire team, and really been so impressed already at the connectedness of the community. It's very similar to Australia in the sense of everyone knows everyone. And speaking of meetings, my honest opinion is that these forums with patients and families are one of my favourites because there are always very challenging questions that come from the floor, and it's really great to interact. And it reminds me as a health professional and a researcher what it's really all about. So thank you so much. So I'm hopeful that my talk will really complement that of Dr. Parker and Dr. G, and a beautiful story from Linda, just a remarkable story. And thank you so much for that. Advance one slide, thanks. Wonderful. So in my time this morning, I'd like to, I think, pivot to a focus on research and clinical trials. And I think the foundation that's been laid by the previous three speakers has been a wonderful stepping stone to what I'd like to talk about. So I'd like to really take three key areas. And the first is really the focus on what is it that makes research and trials in brain tumours, patients with not just brain, but also spinal tumours, particularly challenging. We've heard questions on that already this morning. Secondly, is it time for us to rethink our assumptions and to rethink and redesign our clinical trials? And lastly, to finish on aspiration about the future. And I'm personally very optimistic as well as realistic about what we can all achieve together. So I think as a researcher and as someone who is very involved in clinical trials, both in Australia and internationally, really, I think the foundation remains excellent clinical care by the multidisciplinary team, surgeons, radiation doctors, medical oncologists, social workers, psychologists, nurses, the whole team, family, of course, support groups. That to me is still the gold standard. Despite everything we do, and there are an incredible amount of efforts going on around the world, that remains, in my view, the cornerstone. I thought I'd take a summary slide first to just remind us of when we talk about clinical trials, traditionally the framework is that of different phases, and you've heard about that already this morning, but we really have the preclinical, what we call the laboratory-based studies, which tend to be phase 0. So they're studies that are done not in humans, but really to test dosing, side effects, test the scientific question. Then if there is a positive signal, they are then potentially taken to a phase 1 setting, where that is a study done in humans, typically in a small number of patients, where further really important information is gathered about that particular intervention or study or drug, whatever treatment that may be. And then if there is a positive signal, it's taken on to phase 2, where it's a larger sample of patients or participants. The question is really about safety and about the appropriate dosing, and to check, obviously, signals of, is this treatment effective? Before potentially a phase 3, a much larger study is done in a human population, and obviously significant resources come to bear in a phase 3 trial. In certain studies, there is also what we call a phase 4 study, where there is, once that intervention is released into the broader community, studies on further safety and efficacy, even post-release. So I'm sorry the formatting slightly changed on these slides here, but I wanted to present this table. It's actually from a publication we did from some of our COGNO members about asking the question, well, what is the trial participation and the number of studies available, particularly when you look across the world, as well as looking at it from an Australian perspective. And so this table really compares those countries by population with the number of trials that are brain tumour trials done in that particular country, both single country, as in done in that country, as well as multinational studies. And I think the results were actually quite encouraging in the sense that when you look at the number of trials per capita population, so when you compare Australia to the US, and the US being about 15 times the population, we actually see that, relatively speaking, the number of trials available to brain tumour patients is actually quite on par, actually. And so that was encouraging to sort of see that data, and obviously significant effort to continue to see that grow ongoing. So this slide is asking the question, why is it so challenging to design robust and strong clinical trials in brain tumours and spinal tumours? And I think there are a number of really key reasons why. Firstly, I think we'd all recognise that in people with primary brain tumours, it's a rare diagnosis, particularly when we look at glioma and other rare primary brain cancers. So therefore, the numbers are not large. Therefore, we need to collaborate and connect together to pool and get enough numbers. And it's harder to design trials then because they take a longer time to actually design, execute, and read out. The other important aspect is that there's very complex tumour biology, so that we are still learning a lot about the mechanisms of why people develop certain specific types of brain tumours. And even within IDH wild-type glioblastoma, the most common adult malignant primary brain cancer, there's a lot of what we call differences in heterogeneity. So one person is never the same as the next. And I think that is the challenge. We all know that getting drug to penetrate into the brain is challenging. In a healthy body, the blood-brain barrier is our natural protection. But when we want the drugs and therapy to get into the brain, that unfortunately presents a barrier to drugs getting into the brain and working. And therefore, I think we see the majority of trials that there are what we call early phase, those phase 1 or phase 2 trials done typically in one centre, one or two centres, because they're easier to run that way. And so, you know, that's been the style of particular trials over the last number of decades. Yes, there have been some large phase 3 and trials with hundreds of patients, particularly in glioblastoma. Unfortunately, nothing has significantly moved the dial compared to the Stuck paper that Eric talked about just a few moments ago. So COGNO is our major vehicle to achieve multi-centre trials. Here's our mission. It's self-explanatory, and I think we would all resonate with that mission. And the important thing to say is that in the 17 or so years since COGNO was established by my colleagues, we have health professionals, we have researchers, but we also have a very significant amount of consumer members, both patients and carers, and membership's free and it's very easy to sign up. So I don't want to labour this slide too much, and it's a complex slide, but really just the story in those last 17 years is that COGNO has led a number of very important trials in glioblastoma, NUTMEG, and they all have fancy acronyms because you can't do a trial without a good acronym. NUTMEG was a trial looking at nivolumab and immunotherapy in patients with elderly glioblastoma. CATNOM was a trial that we did with our European colleagues called the EORTC. And I think Australia was the second highest country to contribute to CATNOM, show that we certainly can punch above our weight in international trials. That was in patients with grade 3 glioma. The LUMOS study, which I'll speak about in a moment, was done in patients with recurrent lower grade 2 and 3 glioma, a pilot study in 10 patients across Australia at 5 centres. And the VIRTUE study was looking at what we call a PARP inhibitor, a phase 2 randomized controlled trial in patients with non-methylated MGMT, because we know those patients tend to respond less well to temozolomide, and we need a different strategy, particularly for that group of patients. So the point of this is that, over the last decade or so, COGNO has led or contributed to a number of very key international studies in glioma. And of course, it's not just the trial data that's important, but the really important translational material, the tumour samples, the blood samples, and the links to the clinical outcomes that are really important that we utilise going forward. So the MAGMA trial, the multi-arm glioblastoma Australasia trial, was led by Professor Craig Getty, And I was really a true success and a testament to Craig and his leadership. The MAGMA study, which is closed recruitment last July, recruited 338 patients across 28 centres in Australia. And we did try to run it in New Zealand, and all credit to Catherine and Helen and her colleagues. We did try to run it in New Zealand, but we will keep trying and looking for future opportunities. And we targeted 300 patients across Australia. We recruited 338 patients. And the question that was asked before by the audience was, you know, what the backbone is starting temozolomide with radiation and the 6 months of temodol after radiation, which I think is what Linda had. The two pragmatic questions in MAGMA were, what's the value of starting temozolomide early before the radiation starts, a minimum of 1 or 2 weeks before patients are ready to go, the wound is healed? And the second pragmatic question is, why do we stop at 6 months? Is there a value to continuing temozolomide as if it's being effective, the MRIs are stable, and it's being well tolerated? Those were the two questions in MAGMA. We have finished recruitment last July, and we're still following up outcomes, and we don't have the provisional results yet. But I think that it was a true success. And I think all kudos to Craig. And I think it was a great success. Why was that? And I realized, he's from New Zealand. He was born in Christchurch. That must be why. But all testament to not only Craig, but to the centres, and many of them were regional remote centres, 6 of them. And we actually recruited above expectations through a pandemic. So that's been a true testament to patients and their families. So thank you for that. The LUMOS-2 trial is really exciting for COGNO, and the LUMOS-2 trial is looking at the question of what therapy can we bring to patients with recurrent or progressive lower grade glioma for whom there is really not a standard of care once their tumours relapse. And there might be a long period of time between the original treatment, often many years, and the subsequent progression or relapse. This study is led by Professor Hui Gan, who's a medical oncologist in Melbourne. And this is a really interesting study in the sense that we take patients with evidence of progressive disease. They all undergo new surgery, whether that's biopsy or debulking or maximal safe resection of the new tumour. We profile the new tumour, so we know exactly what their genetic signature is like now, which can be different from what it was like at initial diagnosis. And then we have a special, what we call molecular tumour board, which looks at the profile and works out, is there a mutation or a particular signature that we can target? If there is, patients are assigned to that particular arm that we think matches best. If there is not particularly a mutation that stands out, people are randomised to another arm, which we believe potentially has benefit. So the exciting thing is that this particular trial was funded by the Australian government via the MRFF, the competitive grant process. And we were able to fund 4 through the Australian Brain Cancer Mission. And we've put in a grant application for arm 5. And the additional exciting thing is that on the back of this, our Canadian colleagues heard about LUMOS-2 and were able to secure funding competitively to run this study also in Canada. So it's the first study that COGNO is being able to bring not just to Australian participants, but also to Canada. And Catherine, maybe we should have a chat about bringing this study perhaps to New Zealand. Be really excited if we could bring that, because I know that you have CASP and other studies here in New Zealand as well. I want to pivot now to some thoughts on some new trial methodology. So you might have heard of this study called GBM Agile, which is using this really novel adaptive trial methodology. So let me give you some context. So in the past, our trials are typically designed as one question, one intervention. You design the trial, you have to secure funding for that trial, which is quite a challenge. You run the trial, it might take 5 years. You read out the trial, which might take 5 years, and then you get the answer. And if it's negative, you go, well, we just spent 12 years of our life designing that trial, and then you start the new trial. Is there a better, faster, more efficient way to derive which trials have positive signals to progress, or which trials, on the other hand, which trials should actually be aborted early? So GBM Agile is an adaptive trial whereby patients with adult patients with glioblastoma come into the study. They're randomised to either standard of care or a novel intervention, typically a novel type of drug therapy. And the outcome is recorded, and through quite sophisticated statistical methodology, we can work out, should that arm progress and be expanded and continue, or on the other side, if the outcomes are not good in that arm, should it be terminated early and another arm brought forward? So we have these efficiencies with this rolling adaptive platform within the one large trial. Hopefully that makes sense. So you can imagine designing and running such a trial internationally is an incredibly large undertaking. GBM Agile is open at, I think, almost 4, if not 5 Australian centres, and it will be interesting to see how that trial reads out over time. So apologise again, the formatting changed on this slide, but this is a slide shared by my colleague, Dr. Jim Whittle, who works at the WEHI in Victoria. And this is a kind of a proof and principle about the perioperative study. So there are 2 key questions in brain tumours. And firstly, the question is, does the drug get into the brain? How do we know it's penetrating into the brain at sufficient levels to have efficacy or effectiveness? And does the treatment have the expected effect? And so the POP program is a really interesting ecosystem or paradigm where patients have their biopsy up front, they profile their tumour, they might have treatment before, what we call neoadjuvant treatment first, then they go to a formal maximal safe resection or taking out the tumour, and then they might have further what we call adjuvant postoperative treatment after that, radiation, chemotherapy, other therapy. So the beauty of this kind of system is that it's a foundational platform by which we can test the efficacy of drugs before they're given further. And we have a really lovely longitudinal serial sample of tumour and blood tests from diagnosis through and beyond. This second slide also points out some of the really important infrastructure that we think is required for us to better understand and collate our results. So this was a very significant effort undertaken by my colleague Lindy Deffrey, who's a surgeon now at the Monash in Victoria, where it was a MRFF-funded Australian brain cancer registry. So the point of the registry is that for every case that's diagnosed, it's really precious, that patient, their journey, their tumour sample, their blood sample, their outcomes. Is there a way that we can systematically collect ongoing and prospectively all of that really important data? And I think the answer is yes. So this registry, the vision of it is that we can really harness all that really important information from sites across Australia and potentially beyond. We can map outcomes. We can say, is there variation in practice? Is there variation in outcomes? How can we reduce that variation? How can we make sure that everyone is receiving optimal care? And how can we bring in new treatments? The other really important foundational platform it gives us is that once we have that tumour samples, blood samples, clinical outcomes in hand, that's a platform for future research. And certainly our scientist colleagues are coming to bear in different platforms using organoids and other types of cutting edge technologies. So that is a work in progress. That grant was funded or announced about 18 months ago. And there are certainly moves to bring that all together. And you can imagine how complex that is, trying to bring multiple centres and multiple jurisdictions together. But we're very optimistic about what that infrastructure can bring. Just pivoting now to a study in meningioma, because I appreciate that in the audience we'll have patients and families affected by not only glioma, but also benign brain tumours like meningioma. New Zealand contributed very strongly to the Rome trial. So the Rome trial was run by a UK neurosurgeon, and it was a randomised trial in a typical grade 2 meningioma. We know that meningioma in that grade 2 group have a higher chance of recurring. And the question is, what is the value of upfront postoperative radiation versus observation in that particular group of patients? So this was a trial run in the UK, Europe, Australia, and New Zealand. The final outcomes are still pending, but I think it's important to acknowledge that these trials can be run with Australia and New Zealand contributing to that effort. My last couple of slides, and this is also a slide from Jim Whittle, and I wanted just to pivot to this important theme of supportive care and survivorship. And survivorship, in my view, really is from the point of diagnosis. It doesn't matter if that survivorship is long or if it's relatively shorter or modest. This is a really interesting program looking at 3 key areas. How can we curate all the information, resources, support material, vetted educational material regarding primary brain tumours in one central repository? How can we develop a toolbox for self-management for certain patients and carers as appropriate? And how can we connect the community in a virtual space to share journeys, to share education, information? And I heard obviously from Chris, your opening slides very much spoke to all the efforts that your group has been doing similarly in that space. So the Brain Tumours Online is a really interesting program, also funded by, in part by the MRFF in Australia. And I think what's really important about these online initiatives is that there are no walls, as we know from COVID and from how we need to change our practice through and post the pandemic. And so strategies like these initiatives are really open, really internationally, and it'd be great to be able to connect the New Zealand community to what we're doing in Australia and ongoing. Now, it seems that BRAINS is a very common acronym. We're going to have to maybe change some of these acronyms. But this is a separate BRAINS program standing for the Brain Cancer Rehab Assessment for Survivorship Needs. And this is a group initiative run by Haryana Dillon and Joe Shaw, and they are at the University of Sydney. I'm also involved in this initiative. This is a $5 million program supported by the Australian government. And this is, again, a wonderful complementary platform where they're looking at multiple supportive care interventions. And some of them are listed here, the Brains Adapt portal, Beyond Brain Cancer, looking at online group-based grace support, looking at the really important role of brain cancer care coordination, whether that's done by nursing or allied health staff, understanding what educational needs, resources and training needs, because it's a very specialised area requiring a lot of expertise and experience, and looking at what are the optimal models for which we should be or could be delivering brain cancer care coordination. And so these studies are rolling, and we are looking for, for consumers, patients and carers support to see these studies succeed. And I think the really important message is that these are very experienced, high-level supportive care researchers bringing a very strong research framework to this sort of program. And so I would commend them to you to look out and see what research projects they continue to bring forward. And so in terms of just my final slide or two, in terms of future directions, look, I think that despite the many, many challenges we have in dealing with very challenging tumours and patients, looking after our patients and their families, I remain, after many, many years, as Chris said, I'm embarrassed to say probably 25 years working in this space, incremental positive change. I'm really hopeful that we'll see a tipping point in my career before I retire. Some days I feel that sooner rather than later. I think that we are evolving to a portfolio of both niche trials in a very profiled select group populations. We should challenge our original assumptions about what we think about tumour biology, how does drug penetrate into the brain, proof of principle studies that only realistically certain centres can do. But I do think that some broader initiatives like the registries and broader trials like supportive care interventions really should be things that many or most can access. And so I think there's a role for balancing both the niche and the broader trials. I'm being really impressed by interacting so far through this community, how connected everyone already is. And I think that is something that we need to guard, protect and leverage to see us succeed. And finally, being a researcher and a trialist in this space, I am really humbled by patients and carers who give incredibly so much to see all of these trials and research succeed, not just for the greater good. I understand some of it's to understand personally how your journey can be better and stronger. but really for the betterment of the entire community. So my sincere thanks. So I think that coming back to the summary of the presentation, yes, we do have very specific challenges. I think we need to rethink how we design trials effectively, efficiently for the best outcomes of all. But I'm very optimistic about the future collectively, about what we can achieve. And there are some very significant local Australian initiatives. I'm very interested to hear from Eric about those trials going on in New Zealand, and more broadly, really about the future. And so just to leave you with this slide, and I promise I didn't talk to Chris about this beforehand, but on the left we see, this is our COGNO meeting from 2023. The lady next to me is Teresa Simpson, who's our fantastic brain tumour social worker. She's been in the game for 30 years and she is the boss. Whatever she says, I do. She has an incredible amount of experience. Next to her is our clinical psychologist with also expertise in neuropsychology. And next to me on my left is a wonderful oncology trainee. So it's really a pleasure for me to be able to mentor the next generation of researchers and clinicians forward. And this is a photo we took at SNO, which is in Vancouver, in 2023, and 10 years after I met Chris. So what a lovely bookend. And we hope that that relationship continues strongly. Thank you very much.